Please join me in welcoming your panel moderator, Praveen Soti.
Thanks, Jose. For first submission, there was a lot of overstatements there. So anyways, let's start the session today. So good evening, everyone. Appreciate you all making time for this. The topic is very relevant to what we have been discussing over the days today in terms of moving from how we sort of finance the healthcare today to sort of more of value-based servicing. And over the last at least few years, there has been a tremendous momentum, I should say, both on value-based designs, reimbursements, care delivery models, and there's a host of examples of that. Some, close in our communities where the CalPERS example, where the Blue Shield and CalPERS and HIMSS Physician and Dignity are doing some good work there. And there's some other examples from the international and domestic market as well. One thing to note is while we all talk about ACOs and PCMH, the one thing that we're seeing is there is even the peers are sort of getting onto the bandwagon. Aetna in their last earnings call reported on 25 plus ACOs, contracted ACO relationships. And by some estimates, if you look at some of the industry research, people are quoting on 330 plus. So that shows you a trend, at least there's some excitement. There's obviously some evidence that needs to come out of that, whether there are savings or not. But I think there's clearly a lot of excitement to what these models are. The other example is Aetna actually last year did a joint venture with Innova Health Systems, which is a little out of the league for Aetna in many ways. And so they set up this innovation health plan, a subsidiary, if you will, really focusing on value-based benefit markets, if you will. And then focusing on, obviously, traditional things like wellness prevention, looking at improving patient outcomes through coordinated care. So there's a lot of good examples. So I'll not steal the thunder from our esteemed colleagues. We have 3 speakers today. I'll let them introduce themselves. Alan, Stu, and Connie. So we'll give them around 10-15 minutes each, and then we'll reserve maybe 15-20 minutes towards the end for the Q&A. All right, Alan?
So we spent a lot of time with providers, really talking to them about where is care going, how is it going to be paid for, and how are we going to redesign care. So today, what I'm going to talk to you about is just a little tiny slice of what life might be like in an ACO or managed care network. And I want to preface my talk by saying that at least in our company, where we do a lot of policy analysis and again a lot of strategic planning for large networks and for small hospitals and groups of doctors, what we tell people is it's not so much ACO. I mean, ACO is nice, it's exciting, it's a great buzzword, it's important. Who doesn't want accountable care? I mean, it just sounds like mom and apple pie. But if you look, there was a report that came out recently from, I believe, from CMS, where they actually briefed the director and they said, look, at the end of the day, most of these ACOs are in markets that are ripe for more saturation for managed care. So what I would propose to you is, as I go through my talk, don't just think about ACOs, because ACOs are a model that people are working on. From the government's perspective, it's how do we save money on patients that we don't want to have to tell them they're going to have to go in a narrow network and have limitations from doctors. You get the Medicare card, go wherever you want, but we're trying to decrease money. Most of the providers in ACOs are saying, how can we get this person into our capitated pool? And so what I'm going to talk to you about today is a process, a tool that uses IT to help bring down costs, improve patient quality, et cetera. So let's talk about eConsult. I wanted to show you this question. I have no idea how many of you are in IT, clinical, been patients, but at the end of the day, what's really important for our clients to understand is we say to them, they all want an IT solution. Give me an IT solution because I really need to fix this now. And this vendor over here told me if I buy this IT thing, it's going to fix it. And the first thing we ask them is, what process are you dealing with? And what goal do you have to change that process? So I stole this from someone, Lyndon Crawford. It was obviously created quite a while ago because it has a general practitioner. Most folks don't have general practitioners anymore. You're family medicine or internal medicine board certified. But it's a great picture because when we're looking at eConsult, it talks about the relationship between the family medicine doctor or the internal medicine doctor or the pediatrician and their patient. And the patient has a problem, and the doctor wants, or the PA or nurse practitioner wants to give them an answer, right? But they don't know the answer. They need help. So they're going to refer him to a specialist. So now they say to the patient, go to the gastroenterologist. The patient has to reach out to the gastroenterologist, schedule an appointment, get to the appointment. Gastroenterologist looks at him and says, oh, well, you need these 3 tests. Now the patient has to go get the tests, go back to the gastroenterologist. They say, okay, based on these tests, we're going to do this for you. Send them back to the primary care doctor. Bottom line is, there's a lot of time here, a lot of patient frustration, a lot of opportunities for errors and drop balls between the specialist and the primary care physician as they're working through this process, because there's not real good communication if they're not both in Kaiser, honestly, at the end of the day. And there's also opportunities for morbidity and poor quality of life for the patient. So assuming the patient is in pain or does have some kind of decreased quality of life, and that's why they went to the doctor, and that's why they were sent to the specialist, during this whole time period of runaround, they're actually not getting that taken care of. And that's really what eConsult is all about, is how do you decrease some of that time and frustration and opportunity for drop balls and for patients to suffer. So in the old days, all the doctors went to the hospital. There weren't nurse practitioners and there weren't PAs, and everybody lived at the hospital. They had lunch at the hospital, they had dinner at the hospital. And so if Dr. Jones, the primary care doctor, saw a complicated patient in the afternoon, well, when he went to round on his patients in the evening, he would talk to Dr. Smith and say, hey, Dr. Smith, cardiologist, I got this patient kind of complicated, what would you do? Smith says, well, or send him to me, right? And it was pretty simple. It's called the curbside consult. It was easy, it made sense, but that was back when all the doctors ate lunch and dinner together every day. They don't do that anymore. So we needed to find a way, how do we replace the curbside consult? And so it's really this process utilizing some kind of web-based software. And again, I'll show you one of the ones we've tested. It's a great software in use in Orange County and some other places, but it's not so much the software itself, but the functionality you want to look at. But it's all about more timely access to a specialty care consult, not necessarily a visit. Maybe we can avoid the visit, but a consult. We want someone who sees this condition every day to help us understand how to manage it. We can co-manage. Again, the primary care doctor is supposed to be taking care of the entire patient. And whether you're in an ACO or a capitated model, it's the primary care doctor who's most at risk financially. If they use a specialist, it's going to cost them money one way or another. Either it's going to draw down the savings for the ACO, or it's going to pull money out of the professional risk pool and potentially the hospital risk pool on their managed care side. So that allows them to co-manage patients as opposed to giving away. The other problem is, obviously, if you've got a really complex patient who needs 6 specialists, the question is the primary care doctor going to be able to quarterback and manage them with help, or are they going to be managed by 7 physicians, as many patients are today? It can help build capacity for something called patient-centered medical home. And most of you probably are somewhat familiar with patient-centered medical home, but it's this whole idea of team-based medicine, one-stop shopping, wraparound care for patients. Some folks are paying more for those kinds of models now. It can reduce unnecessary referrals to specialty care and to the emergency department, because if the primary care doctor refers the patient to the specialist and the specialist doesn't have an opening and the patient's still in pain, guess where they're going to go? Every patient thinks that every specialist lives in the ER. And so that's where they go to get specialty care when they can't get it otherwise, particularly in safety net populations. It can improve patient satisfaction because, again, they don't have to run around to all these different doctors. And finally, you can save money. Specialists are expensive. Emergency room visits are expensive. So can we use less of them? So some of the advantages, very specific to eConsult and why we've used it in some of our work as we go into clients who want to decrease total cost per patient, is we say to them, well, your PCP and specialist, they can actually share notes. And I'll show you an example of the model. They can actually talk to each other securely. It's a form of secure messaging. It's not as quick as text, but they can go back and forth. They can also share diagnostic findings and lab results, even if they're not on the same EMR. So again, this is an example where you're not in a Kaiser system, where everybody's on one Epic, one seamless system. Not that they don't do e-consults within Kaiser, but this can be done, of course, across people who are in different systems. Your specialist can provide recommendations without necessarily seeing the patient. And it's flexible for the specialist, because we initially thought, well, we'll try telephone, right? I mean, everybody's got a cell phone, but the specialist can't answer their cell phone every minute. Maybe they're in a procedure, maybe they're seeing patients. This allows them to do it on their mobile device whenever they have time. So you can improve quality of patient care because your primary care doctor now has more information. They can make better decisions. You've got improved care coordination for your patient. You actually, one of the nice things about eConsult is now what happens is when the primary care provider, again, PA, MD, whoever it is, goes to make the e-consult, they have to answer a series of questions that are based on evidence-based guidelines. And so actually they're learning as they're making the consult. Sometimes they won't even finish the consult because it'll say, did you do this? Oh, no, I didn't. Let me go do that. Oh, great, done. Don't have to make the consult. So it really integrates consensus care guidelines. And we mean consensus means you take the national evidence base, but you realize that healthcare is local and doctors are proud of the way they practice, and you get the primary care doctors and specialists within a narrow network together, and they agree on their guidelines, which are going to be 99% close to the evidence-based guidelines, but customized for their environment. And again, you're going to prevent referrals. We talked about that. And very important, as opposed to curbside consults and phone consults, is you're going to track your documentation. So you actually have tracking of what the conversation was, how the recommendations were made, so that way what can happen is you can track cost, you can go back and track learning if there's a mistake, etc. Okay, so that's some of the advantage. So this is for the software we used. This was the interface, pretty simple. You log in, and again, it was available on your mobile device or on a computer. Again, I'm not here to sell software, so I just giving you an example of what it looks like. But it was very simple. So you've got your specialist. You just say, who's the payer? What's the specialty? The guidelines are right here. So this PDF is cardiology guidelines. So if I'm a primary care doctor and I've forgotten how to treat a heart failure patient at a certain step, I can open up the guidelines. Oh, that's how it works. Again, it's like email, secure email. It's HIPAA compliant. You put your email in here, and you can see down at the bottom how it can work in real time. So this is your primary care physician or your PA, and patient's 23-year-old male. I don't even know what the hell IFOBT is because I'm not a doctor. Okay, you've got a problem that's spelled IFOBT. Stomach pain, history of family, colon cancer, etc. Specialist writes back right away. Did they take Tylenol yet? And that's the kind of simplicity you can get. I mean, they're really, many of the consults we find are at that level of simplicity, and it can become more complicated, obviously. The specialist can pull up the x-rays, they can pull up the lab tests, they can help you understand, are you going to tweak the patient's medication? So, again, if you can imagine being the patient now, especially a patient who can't, like the rest of us, it's easier for us to take off work, but if you got a Medicaid patient or a new exchange patient and their employer doesn't let them take off much work, they go to the PCP, right? They go to the visit. The PCP makes a preliminary diagnosis or maybe 2 or 3 potential diagnoses. They get some tests done, they've got some questions, they shoot it to the specialist. Patient goes home. The next day, the patient gets a call from the clinic. Mr. Smith, your doctor has conferred with the specialist, and they're going to change your medication. So please go to the pharmacy. They'll be waiting for you tonight. You can pick up your new medicine, or maybe your medicine at all. And you know what? We've got a little bit of a change of how we want you to take care of yourself. So you can imagine it's much easier for the primary care clinic to care for this patient without multiple visits all over the place. So that's what this is for. So again, for today, this is an ACO talk. So what I wanted to do was kind of review with you one of the tools, an IT tool we can use to bring down costs in an ACO or managed care. And again, to me, it's really capitation. DSRIP, by the way, is Delivery System Reform Improvement Projects. It's how Medicaid is changing across the country. Again, paying for outcomes, paying for lower costs. And so at the end of the day, e-consults save money. We've done some research, and other folks have done research, and there's clear evidence base that you can reduce specialty visits by 50%. So right there, you save a lot of money. Now, obviously, you have to pay the specialist for the e-consult, but it's a lot less expensive than actually going to their office. There's a forced standardization of processes. The way you refer to specialists, the way the staff in the office now orients around a specialty care visit becomes standardized because it's all electronic, as opposed to having the many different systems we have now. You're also, again, going to be able to diffuse and adopt clinical guidelines, so you start treating people the same way. You can track and monitor utilization much better than you could without some kind of electronic path, obviously. And again, the patient increases their affinity for their primary care home, which in an ACO or managed care environment is absolutely critical. That's how you're going to save your money in your ACO, and that's how you're going to, in fact, in an ACO, if you understand how they work, that's actually how you get to keep your patient, because patient assignment is based on actual visits to that doctor. If they're visiting a specialist too much, they can actually get switched. So it's more one-stop shopping. So what are some of the critical success factors? If you want to make something like this work, this is what we do for a living, obviously, is You really have to engage your providers. And again, so this is more of a big picture, if you want an IT project to work with providers, what do you have to do? I can't tell you guys how many times I go into an institution and I'm talking to administrators and they're trying to make me understand why they desperately need this IT solution for this process that's clinically driven. And I ask them if they've talked to the doctors and gotten the doctors involved, but the doctors are too busy. They see patients. We do process. They just do what we tell them to do. That's not going to work. And so you really have to get those providers, physicians, PAs, involved in this process from the beginning. And they have to help you design the process. It does impact how people work. You need to think about teaching primary care providers how to ask questions of specialists. Okay, they don't learn this in med school. They don't get taught how do you make a specialty consult. So they have to learn how to ask questions that are going to get the answers they need. There's a lot of training involved. And clinician-to-clinician dialogue. So not only 3Consult, but when we put together a program like this, we also, God forbid, have the providers actually get in a room together once in a while and talk. We had, at one client, we had what we called community grand rounds. We got all the primary care doctors in the network together with the specialists so they can have conversations, talk about how it's going, make sure our guidelines are on track, problem solve, et cetera. It's all about trust. At the end of the day, it's person to person, just like anything else. And so getting those primary care doctors and specialists to trust each other and to trust the system. You have to align financial and productivity incentives. So our company also does a lot of health workforce training, and I took one of my alumni out the other night. He's a PA, and he's having eConsult launched in his practice, and he was upset. He says, oh my God, I have 15 minutes to see a patient. My patients are really sick, and now they're making me do this eConsult. You know what's going to happen, Alan? Damn it, I'm not going to be able to refer them to the specialist, and I'm going to have to manage it myself. And I said, well, that's the point. That's what we're trying to do. But what's happening at his site is they haven't walked through and thought about, do we have to expand primary care capacity? Are we incentivizing our primary care providers correctly? So, again, you can't just launch the software, launch the system. You got to think about what's the impact going to be as you succeed, because from your point of view and your client's point of view, success means more primary care visits. But that has a real impact on that practice. So are they going to add doctors? And what are the finance folks going to be doing and thinking about to make sure they shift the money and the profits around so that there's the right capacity in the right place? Again, adaptive clinic practice workflow is critical. You actually have to look at how the specialists do their work in their clinics and the primary care doctors. And finally, the role of support staff. So it's not just doctor, not just PA, but the other staff as well.
Good afternoon, everybody. My name is Stu Gross. I'm a consultant at the strategic IT level in not just healthcare, but other industries. I'm going to talk about ACO and patient care medical home, and those are just two modalities. What we're going to be talking about are tools that could be used in any patient care setting where there's a centralized focus on who's managing the patient. So first I'm going to tell you a little history, some things that maybe people aren't aware of, especially if your whole career has been in healthcare. We're way behind the times. We are so far behind every other industry. I started in finance in the early 1970s, working in New York City. And in that business, what happened was banking began to use OCR in the 70s and 80s to encode checks. The stock market started in electronic processing. By the 80s, they had eliminated almost all paper stock transactions. Even if you got a certificate after the fact, the trade took place electronically. And banks began to use direct electronic transfers, things that were unheard of in healthcare. My theory behind this is, and we're going to talk about a couple of other industries, is there were central players who said, this is what you have to do. It was the Fed and the SEC. They said, you have to do this. Here are the rules. This is the game. You have to play the rules. They were the leaders. In manufacturing, General Motors and Ford were the two leaders in the 70s. They ruled the roost when it came to automotive, and automotive ruled while manufacturing. I had a consulting firm in Connecticut, worked in New York, New Jersey, and Connecticut for many years, and manufacturing was what we specialized in, ERP systems. And what happened to my clients, who were the manufacturers that supplied parts and pieces to General Motors and to Ford, General Motors started it. They came out with an AIG requirement for barcodes that had to go on the boxes of all the parts and on the individual parts if the parts were big and they weren't in a box. Barcodes hadn't even existed before. They invented barcodes to make their life easier. They told my clients, if you don't use barcodes, you can't ship me any product because I won't receive it if it doesn't have a barcode on it. Then they followed up with EDI standards, again, the first to do it. The beginning was you had to bill us by EDI, electronically. The next was we're going to issue all our purchase orders electronically through EDI standards that they created, their own standards. GM and Ford did this together. And then it came to packing lists, purchase orders, every step of the way where there's almost no paper involved. And again, it was, by next January, if you're not able to deal in electronic stuff, you can't do business with us. They had the stick. In the 80s and 90s and into the 2000s, EDI expanded to shipping notifications, and that led to just-in-time delivery. Something we've all heard about now with Walmart, but this was happening already 30 years ago in the automotive industry. And along came Sears and Penny's, the only two national retail chains in the 1970s. There were no others. And they, again, were the central dictators as to what to do. And they did is they latched on to what automotive had done, because the same manufacturers were making products for JCPenney's and for Sears to sell in their stores. I had 4 clients who served both automotive and retail. One of them was in the lighting business. He made bulbs, he made headlights, and he also made lighting fixtures. JCPenney's, they they followed the standard. Okay, you're going to ship us a box of parts, a box of items to be sold. This is long before UPC codes. You need to use code 3 of 9 barcodes on the box to tell us what's in there. And then EDI standards followed right behind that. In the 90s, EDI expanded again to shipping notifications just in time, and UPC barcodes came into play in the 90s. Not that long ago. It seems like they've been around forever, don't they? And just-in-time electronic delivery took place there also. Okay, healthcare. Why are we behind? Well, there was no centralized force in healthcare. There still is no centralized force except for the government, all right? And the government just stood by all these years that all these technology things were taking place in the other industries, and they didn't make any demands except a few in Medicare. But essentially, healthcare was run on paper. And when I'm talking about paper in healthcare, I talk about communication between different organizations. Within an organization, things may have advanced, some computerization took place, but there was no sharing of information outside electronically. Some barcodes started to take a place on supplies to make things a little more efficient. And HL7 standards, they weren't even created until 1987 and really weren't implemented until the 90s. And we still, as we heard this morning from somebody, there's still organizations out that are using systems that don't have HL7 capability. So in the 90s, finally, some barcodes gained momentum. HL7 came about and was implemented as a standard. And now, in 1996, the first centralized demand on healthcare to do something, okay, allowing the sharing of information, EDI transactions, data warehousing started to begin at this time, although it had been, again, in place 20 years in other industries. And now, in 2010s, the Affordable Care Act. So the government has taken the role that didn't exist. Healthcare was a siloed industry. It still is. Every hospital organization stood by itself, and the real silos were the individual physician practices. There was no communication between them except on paper. So my take is the purpose of the ACA Act, it's all about the patient, and that's what it really needs to be about. I'm talking about technology, but we need to look at the technology to make things better for the patient. We know that money is the thing that drives business, industry, hospitals, physicians, healthcare organizations, insurance companies. Money drives them. Now, we need to do is what the ACA attempts to do is to find a way so that these organizations can make more money, but at the same time, the patients get better health care. Okay, so it employs carrot and stick, all right, incentives. We all know what they are, okay? Go out and get yourself an EHR and I'll give you some money. Oh, you didn't use it very effectively. Well, I'm going to take it back in 2 years later. The other thing with technology, now we'll get to the meat of my topic, big data. We talked about, Alan has talked about ways to get doctors to communicate, to make things easier and better. We've also looked at, in previous sessions today, the challenges of the data because the systems are disparate. They don't share. The government set out all these rules that EHRs are supposed to be interoperable, and they're not. All right, there's some efforts. So what can we do? Eventually, interoperability will be here. I'm sure that over time, Epic will talk to Meditech, and Meditech will talk to Cerner, and everybody will be very happy. But in the interim, we have a job to do. We need to provide better patient care. There's so much information available everywhere. There's information not just in your hospital, there's information on the internet, there's information in the doctor's office, there's information everywhere, and it all can be pertinent to providing good care to your physicians. Okay? My take on what we need to do, there are tools available now, and I'm not out to sell anything, so I'm not going to mention who they are, but there are multiple companies that have tools that will allow you to do all of these functions that we're going to talk about here. And they have crawlers that can go out and pull data from every kind of data source there is. It can look at your Epic file. It can go look at the doctor's office where they have XYZ EHR. It can actually crawl the internet looking for data that you're looking for. It can crawl best practice websites or publications. It can crawl any place that you want, and if they don't have a crawler for it, you can create your own crawler. They have that ability built in. And what the goal to me is to look at all this data, find out what's pertinent. There are ways to do that. It's built in. We're using natural language processing, looking for pieces of data, pull that data and put that data, which is unstructured, out of your email, out of your notes, out of letters, put that data into structured databases. Find not all the data, just what you believe is relevant. We need, and then we're going to identify and analyze cohorts. And what I mean by cohorts is find all, let's say you have a patient, and what the goal is instantly, if you're in front of if a patient's in front of a physician, and he's got your whole medical history and all the information about you, you'll be able to push a button and go, if you have a problem, he wants to know what's the best practice. Not the best practice that might be published isn't always the best practice. You push a button and it can go out and look at and find 500 people that have a lot of similar problems, issues, or healthy practices that you have, and look at them and be able to see the best outcome that came from which group of people and what was the methodology used to gain that outcome. And this is the way that healthcare can really, really advance as we move on in our time. Provide appropriate care, help prevent diseases, look at people who are healthy, find cohorts that have that same pattern, but 6 of them ended up with some disorder, and try to have the system can look at the pattern to see what was a little bit different about them. But all of the elements, my gosh, in healthcare, this is all the things we need to look at. Electronic health records, we all know about those. There's lots of good data there, but there's claims data, lab results, RX fills, not just what was ordered, but what was filled. Fortunately, in California, we have a standard for that, and that's readily available. OTC meds, you need to make sure that that's in the patient's record. Radiology studies, unstructured reports. There is no structure to those reports that the radiologists write. And I know SNOMED is on the horizon, and we're trying to get there, but it's a long way off. So we need some tools that can crawl these reports and pull the pertinent data. Same thing with surgery. Referrals and authorizations, they have notes attached. The notes may be the most important piece of information that's on there. Durable medical equipment in the hospital, all these messages traveling back and forth about what's going on with the patient. Okay, they're used in the moment and they're gone. Well, let's capture those, okay, and get the pertinent pieces of information and put them in a database. Correspondence, Word documents, a doctor might still be doing a regular referral letter to a specialist that's in a Word document that he's sending. Family history, HL7 messages that are flying around like right and left and everywhere. And then what do we have in the known disease and disorder characteristics and treatments? And if we can glean all this information, pull it out, all right, the technology is there to put it all together. The missing link up to this point in time is capturing the unstructured data, and the technology is there to do it now. So we need new tools. We can capture structured data, unstructured data from within our organizations, from outside of our organizations on the internet. And then the most important role here is we need clinicians to work together with us in IT, because in IT, we know how to get things done, but we don't know what it is that needs to be done. We need the clinicians to help us understand what kinds of information do we need to know about a patient to make good decisions so that we can build it into these tools. Be able to identify the relevant data, identify the data that might be unstructured, and then create instruction sets for the crawlers. I'm getting ready to wrap up here. So we need to create and append new databases to the house captured data, create tables from relevant unstructured data, employ enterprise search. Once we have all this unstructured data, we've pulled out the pieces we need and we put it in tables that we know how to analyze. Now we can apply tools from any one of the sources for doing analysis on data. And again, pull out cohorts, analyze, predict diseases and disorders and outcomes. And then we apply best practices to cohort predictions and prevent and treat the patient. And that's it for me.
Thank you. Woo. And I'd like to thank Southern California HIMSS chapter for inviting me to be at this very wonderful program. And also my fellow colleagues up here. We had a lot in common, which you'll see. And I'll tell you a little bit about myself, maybe 2 sentences. I'm a nurse. I have an MBA and a fellow in HIMSS. I'm an independent consultant, and I work in the field of healthcare information technology, issue analysis, and all kinds of things. I have had my stint developing and designing systems. I have been an executive in the administration office. I've been a teacher in teaching operating room technicians how to work in the operating room in a sterile environment. And I'm still going strong learning about what else I can do. And I've got that plan too, I think. So I'm very happy to be here. And today I'm going to give us a little further information about the patient-centered home, medical home, which is not what you think it is, I don't think, and also a little bit about telehealth. And I'm going to tell you a little bit about, I've learned so much today that I'm just going to go very quickly through these slides because some of it is double entendre. We've heard it already today, and I'll do a little bit of my take on it. What is a patient-centered medical home? Patient-centered medical home. It's a team-based model of care, where the primary physician is in charge. And what they're doing now is trying to make the patient feel more comfortable, as you saw today, and also have access to all the services that this particular patient may need without going through a lot of hassle. And that's more like an open setting, an open plan for the patients, very different from what we have today. We're going to look at the patient and assess and give the patient the tests. The patient should not have to go to another building for a test. Everything's going to be close by. So there'll be some architectural improvements besides communication efforts and, of course, the support of our ever-loving computer system. So what I was just going to mention about when I say open plan, you can look at a hospital like the hospital is like either a castle or it could be like City Hall. You knock on the door of the hospital, you go in, and there's a mayor and a city council. Or if you're going into the castle, it's sort of the same thing. Behind every door is a king and a queen. In radiology, there's a king and a queen, right? And we also have a different culture in each one of those departments. Those things really give a lot of work to us consultants because the culture is what we have to understand, isn't it? It's people. So when you look at a patient-centered medical home, we're going to improve upon what we deliver to our patients. I'm a nurse, and that's very important to me, to improve what we do for patients. What I do when I'm in a doctor's office, I sit and talk to the rest of the patients. I talk about patient engagement. And then all of a sudden the doctor said, well, you've got your appointment, Connie. You've got to go in there. And they say, no, we want to talk to you. We want to use the computer. We want to know what's going on. You can find out so much in a hospital. And just remember this. Open the door and find out what the culture is and who the king is and who the queen is. Okay? So now I have my open plan with all the services, my patients in the middle, and we are going to improve upon our care for patients. Who's involved in this now? Any organization you can think of. I've got a list of them here, and there's probably, 300 more, and I'm not going to read all these. By the way, you can email me, and I'll send you my slides. There's going to be a lot of references there that might be helpful to you, or you can get from Southern California chapter. So I'm going to race now because I've got to race. Some of the benefits that we have and are looking at are patient engagement, and you've all heard a lot about that today. And I'd like to tell you, not tell you, but talk to you about how do we get patient engagement? I worked on the budget for the California state, the one we first did for patient engagement, and couldn't find any. No one had a budget. No one. You know, we wouldn't be here if it weren't for the patient, right? So now we're finiting. We've got to know what it's going to cost to get the patient engaged, and they all seem to want to use that computer with and the most important thing to get them engaged, at least that's what they say at Proficient, is to have them use portals, patient portals, and you've heard a lot about that today. Now, some of the challenges. The United States of America is on the brink of a longevity revolution. By 2030, the number of older Americans will have more than doubled to 70 million, or 1 in 5 of every Americans, and you all know that, I'm sure. I don't know whether it's been told to you this way, but I'm just sharing this with you. The future is about to look radically different, and it's unclear whether Americans are prepared to, face the changes. And also, we've heard a lot about HIEs. I'm also going to deliver some recent information on Northern California HIEs also. The status of HIEs surrounding the network implementation and ability to exchange patient information is very important too in patient engagement. Believe you me, that's where they all come together. Now, I'm just going to go quickly through this. 3 days ago, I interviewed Dave Minch. He's up in Northern California. He works with the HIE, and he's the COO of HealthShare Bay Area. And he says the overall project of connecting the Bay Area hospitals and provider organization has recently taken a hiatus, allowing more time for the individual health care system strategies to mature. Other HIE efforts that are going along in Northern California include Santa Cruz, HIA, Redwood, MedNet, and Connect Healthcare. And he said it's because of the emerging ACAs that several integrated delivery networks in Northern California are starting to build their own private HIE. So that's what's starting, the private ones first, and we'll be going to the other ones as time goes on. And this will enable these private HIEs to collect data and control their own analytics. And we've heard that word a lot, haven't we, today? Analytics and getting a lot of subject matter from the data that we collect. But they still will need to interoperate, interoperability, we have that word, with other organizations, including physicians, hospitals, and other HIOs. Now, in summary, and I'm done with this slide now, with patient-centered home. A patient-centered medical home initiative can achieve its goals by adopting new technology, care delivery methods, and relationships with patients and their families, and that will encourage primary care to be patient-centered, comprehensive, coordinated, accessible, and committed to quality and safety, so that we're on a new road there. And references, there's references, right, listed there for you on my slides. Now we're part 2. We're into telehealth now. Telehealth by my standards, cutting edge telehealth. And there we have the doctor talking to a patient who is remotely connected. And this is, I'm going to have to just pick a few things here, cherry pick. We're going to define, I have some objectives here, and we have this done more or less in an academic fashion, because I use these slides to teach 2 universities classes at Cal State. We're going to define telehealth and telenursing. We're going to look at the populations and the role of the telehealth nurse and some of the benefits, and also some of the equipment. I think you'll find it very interesting. Telehealth is the use of electronic information and telecommunications technologies to support long-distance clinical health, patient and professional health-related education, public health, and health administration. And this is, the next sentence is very important. Here's where we see the patient experience and perceptions of care are essential metrics of patient-centeredness Don't you love that word? Centeredness. Don't forget it. It's important in these two elements. Technologies include video conferencing, the internet store, and forward imaging, streaming media, robotics, and wireless communications and social media. Now, we're using this in various settings, and I'm thinking of the patient's home, and I've only got 3 minutes, so I'm going to race much faster. Telehealth cases, usually involve chronic diseases. I don't have to tell you what those are. The nurses are the presenters of telehealth. There's public health nurses, and I want to tell you about 2 programs in public health that are very important. Text for Babies. Women who are pregnant can sign on for free telehealth and telemedicine regarding pregnancy, and they get that on their iPhones. And also Text to Quit. Have you ever heard of that? Those are alerts for people who want to quit smoking, and that comes on your telephone and so on. Now, there's some equipment that I wanted to tell you about. I really like these pieces of equipment. Have you ever heard of the Physio Glove? Okay, the Physio Glove is a medical device that eliminates the problem of electrode misplacement and the entanglement of lead wires. Have you ever had someone put on the lead wires on you that didn't know where to go and how to do it? They can't hardly ever make a mistake with this. So it makes it very clear and very easy to do the EKG. And next we have the stethoscope, the electronic stethoscope. It improves the sound capability. That's what it really does, and it amplifies listening to the patient's blood flow. In fact, you don't have to have a certificate to learn how to use this. It actually is very, very accurate. And then we have the spirometer. I like this. It can interface to a printer which will print out a full report, and it makes diagnosis easier. And then we have what I say is the the otoscope, and that is for ears. Do you know that we have 30 million earaches in our country per year that we have to look and get the otoscope out? Well, this one has a camera. Makes it very, very useful in diagnosing patients. And the telehealth of our fingertips, well, let's say it's making it possible for patients to stay in their homes and still receive 24/7 monitoring. Like when they recover from surgery, they're out of the hospital and they're at home. And I will just say that. Here's the good news. About 2.8 million patients were remotely monitored worldwide at the end of 2012. That's pretty good. It's growing, growing, growing. Telehealth is in a mature industry now. It's used to monitor 1 million cardiac patients a year. 80% of the patients treated for neurological diseases are currently remotely outside the hospital, with 400,000 virtual visits were provided last year to mental health patients. We were talking about behavioral health. This is an aspect of that. And I'm not going to go through the challenges, but this is what I wanted to share with you. I put in healthcare informatics because in all these areas, we have to have an understanding of healthcare informatics in all the fields that instead of structured data, in unstructured data, we want to collect structured data so we can do better analytics, and analytics was a key thing that we did today. Now, the future, these are 2 or 3 things that I'll end up now talking about. According to Dr. Roy Schoenberg in January 2013, he says telehealth is a watershed. It's continuing to morph in front of our very eyes with more technology, with more penetration, and with more mobile broadband. This is one of these technologies that life will never be without. It's growing. Telehealth is poised to take center stage nationwide, according to the experts at the National eHealth Collaborative Technology Crossroads Conference on November 27, 2012. And lastly, my own crystal ball, I'm going to tell you from my own crystal ball, the last thing is I think as the technology is getting smaller and smaller and smaller, that we're going to have something like our Dick Tracy watch. Our hospital visits will be much less. I don't know what the hospitals are going to do. They're going to have to rearrange their beds. We won't need probably as many because we're going to keep many out of the hospital with the patient-centered medical home and our, kind of, I may be stretching it by saying Dick Tracy, but maybe you can change the name for me as we go along here. Because I was one of the ones that predicted that someday we were going to be able to start our electricity from afar, from our car, and start our baking in our oven, and do all those kinds of things. And we can do that now, can't we? Now, so I'm sticking my neck out here by saying the Dick Tracy watch. Maybe it's the nurse watch or something, but we are getting smaller technology, and I'd like you to kind of think about that when you think about my presentation. Thank you very much, and I'm so glad I came today. Thank you.